I want to introduce you the very nice case report that is offered by Tanya, Trinh from Australia. She's dealing about a case of fungal keratitis with a lenticle extraction, smile, and the treatment that happened to be used with Losartan following the treatment of the infection. Indeed, she got an excellent outcome with the resolution of the infection and also with the improvement in the corneal transparency. Please see this very interesting case report because you will learn a lot. Thank you.
Hi, my name is Dr. Tanya, Trinh. It's an honor to be presenting at the Alicante Refractiva Internacional meeting. I'm presenting a case on fungal infection in laser-assisted lenticle extraction, or LALEX, and the role of Losartan therapy in corneal scarring. Thank you for having me. So the incidence of any postoperative infiltrate in LALEX is approximately 0.3%, and the prevalence of fungal keratitis after any sort of laser refractive surgery was about 0.00041%, so quite rare, with the predominant infection being a bacteria staph. If we combine the two, the prevalence then of fungal keratitis after LALEX is extremely rare and likely underreported. There are 2 reported cases of aspergillus keratitis in our warmer countries, and we are reporting on the first case of Candida parasilosis in LALEX infection and the first clinical use of topical Losartan to treat post-infectious keratitis interface haze. This is a case of a 26-year-old male radiology registrar who presented after 2 weeks of LALEX surgery in Korea. There was a speck in his vision at the left eye thought to be a foreign body, which was irrigated at the 2-week mark and commenced on ciprofloxacin and fluorometholone. He then flew back to Australia. Now we are 1 month after the operation, presented to a peripheral teaching hospital with irritation, photophobia and injection increasing, and was commenced on steroid 2 hourly. Obviously, his vision reduced to count fingers, and he was referred to my hospital department here at Sydney Eye Hospital. This is a picture and the accompanying OCT of the density and the location of those infiltrates at presentation. The interface specimen was obtained using a balanced salt solution cannula and washed out then with further balanced salt and a combination of vancomycin. Here we are at day 37. We managed to get a yeast confirmation fairly quickly. We then switched to a voriconazole washout of the interface and commenced the oral voriconazole and the topical amphotericin and voriconazole in addition to the ofloxacin. And a few days later, we can confirm this as Candida parasilosis and switched to amphotericin in terms of the washout, but continued all of the other therapies with the addition of doxycycline to treat any melt and the addition of cyclosporin to control the inflammatory response. Not surprisingly, our hesitation to use steroid did increase the inflammatory response, which was necessary. At this stage, we introduced some dexamethasone 4 times daily because we felt we had an identification of the bug and that we were on appropriate therapy. But really now he has to sit his examinations for radiology soon, and his sight's very important to him. But he had a significant amount of scarring and a mud-cracked interface, and which you'll see in the pictures soon. And at this point, we commenced the topical Losartan drops. So this is a picture of him at 6 weeks post-op. His vision was count fingers with no meaningful refraction accepted. This is now him into 4 months of Losartan therapy, vision improving to 624, and you can see that the density of the scarring is starting to fade, although the macrostriae are still present. This is the accompanying OCT and epithelial thickness. You can see there's a fair amount of flattening at this point with epithelial remodeling, but there is a fading, certainly, of the hyper-intense signal on the OCT at the 4-month mark of Losartan therapy. This is what he appears like at 12 months after Losartan therapy. His vision has improved to 612. There is obviously a significant amount of flattening ongoing and epithelial remodeling over time. The scar, however, on OCT on high magnification obviously seems still quite dense. So Candida is a commensal and can be acquired exogenously from the hands of healthcare workers because we tend to be quite colonized with these. It has a propensity to form biofilms and is highly susceptible to amphotericin B, which explains the switch in our treatment and rationale. Unfortunately, though, Candida does secrete hydrolytic enzymes, which probably contributes to the stromal scarring at the interface and that flattening that you see with the loss of stromal capacity, and it does bring into question whether we should be masking for all keratorefractive procedures in the same way that we mask for intravitreal injections. But how do we deal with the interface striated haze? And we really have to thank the work of Steve Wilson and Licia Pedral-Sampaio for looking into this. Is this the real deal, or this is false hope? Now, the Losartan is known in heart medicine world as angiotensin II receptor blocker, and it acts on the TGF signaling pathway. Now, it normally exists in low levels in the corneal stroma, but when there is a breach of the epithelium or the endothelium of the cornea, of Bowman's, then you get an increase in that signaling pathway, and it causes more fibroblastic activity in the corneal stroma, resulting in retrocorneal membranes and corneal fibrosis, etc. So they went on to look at this in animal models and mimicked a posterior stromal injury in the context of a desmetorexis only procedure, and found that topical Losartan did inhibit corneal fibrosis, but there was no effect using oral supplementation here. They looked at this in the context of anterior stromal injury and found that again this decreased myofibroblast mediated scarring fibrosis. They then looked at intense PRK, so this was a -9 PRK treatment in rabbits, and found that it also reduced the late scarring and fibrosis that occurred in the white rabbit model. And they also looked at severe PTK injury on the white rabbit model, and found essentially that the use of Losartan also decreased the scar-producing stromal myofibroblasts. There's only really one known case report currently in the literature for humans treating corneal haze after LASIK, treated with cyclosporin and Losartan in this context. And interestingly, this patient at 4.5 months after initiating the topical therapy, the vision improved from 2200 to 2030 uncorrected. So that's quite a significant improvement over time. But it does beg the question, would this have done so on its own anyway? So in terms of the potential usage of topical Losartan, obviously for any of our refractive surgical procedures, perhaps there's a role for treatment in burns, infective keratitis, late haze, or other fibrotic diseases. And for your own edification, there is the dosage listed here. It is 0.8 milligrams per mil. It is quite intensive at 6 times a day for a minimum of 6 months, but is generally considered to be quite safe, although it needs to be made clear that this is off-label treatment. This is a picture of the patient along with the OCT, epithelial remodeling, and pentacam imaging to show that his vision had improved to 6/12. So what else could we have considered in management of this case? Well, perhaps we could have waited and it would have resolved away on its own. Could we have used alternate medications in this context? Would there be a role for improvement of vision in a contact lens? Would there be a role for further TGPRK in terms of managing that flattening or that interface? Probably not, because it's quite deep, but perhaps the resurfacing itself might improve some of the corneal optics here. Could we have truncated the flap entirely, knowing that the residual stromal thickness would be quite thin, so perhaps not quite an ideal situation there? Or could we have performed a transplant, which I would obviously consider to be quite excessive in this case? Thank you so much.